Good evening, everyone, and welcome to Exploring the Brain. I'm Dr. Brad Schlaggar, pediatric neurologist and president and CEO of Kennedy Krieger Institute. Thank you so much for joining us for this evening's webinar on autism and mental health. Now, we know from both clinical experience and a significant number of clinical studies that people with autism have a higher rate of co-occurring mental health diagnoses. Diagnoses like anxiety, ADHD, affective disorders, and others at a higher rate than is seen in the general population. And for many autistic individuals, it is these co-occurring conditions that result in the most clinical burden. So we have an expert panel here with us tonight to discuss this important topic, but first, a few housekeeping notes. If you have a question at any time, please use the Q&A button, likely located at the top of your Zoom window. Just click and then submit your question, and we'll try to get to all of the questions during the Q&A period at the end of the panel discussion. The webinar is being recorded, and the planned discussion will be about 60 minutes with a roughly 15 minutes or so question and discussion time at the end. Now, I'm very pleased to introduce our expert panel, four of my extraordinary colleagues at Kennedy Krieger, and they are Dr. Luke Cowell. Luke is the Director of Informatics at the Center for Autism Services, Science and Innovation, Kennedy Krieger Institute, and a faculty researcher in our Department of Neuropsychology. He's also an assistant professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Amy Kiefer is a pediatric psychologist at Kennedy Krieger Center for Autism Services, Science and Innovation. She's board certified in cognitive and behavioral psychology, and she's an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. Dr. Dan Hoover is a clinical child and adolescent psychologist at the Center for Child and Family Traumatic Stress at Kennedy Krieger. He's an assistant professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins. And Dr. Roma Vasa. She's a child and adolescent psychiatrist who directs psychiatric services at the Center for Autism Services, Science and Innovation. And she's a professor of psychiatry in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins. So welcome, Luke, Amy, Dan, and Roma. And before we get started, I'd like to briefly talk about language. You know, in the autism advocacy community, there are some varying perspectives on language. Some prefer the use of person-first language. For example, John is a person with autism. Others prefer the use of identity-first language. Jane is an autistic person. So now at Kennedy Krieger, we recognize and respect these perspectives and take no position on which is preferable. We think that the most inclusive approach is to use the language interchangeably and, whenever possible, ask an individual how they would like to be identified. Also, for those who are new to the conversation about autism, the current rate of autism diagnosis is 1 in every 36 people in the United States per the CDC. This rate has been steadily increasing and is thought to be driven by several factors. So with that said, let's get started. Roma, let's begin with definitions. Definition of autism and autism spectrum disorder.
Autism or autism spectrum disorder is a neurodevelopmental condition, and it's characterized by difficulties in two areas: social communication and restricted repetitive behaviors and interests. So in the social communication area, a child may have difficulty with social interactions, and there's a wide range of difficulties and how this may manifest, ranging from not being interested in being with others to wanting to be with others, but perhaps struggling to engage in conversation. Children may have less eye contact and use of gestures, and they may have difficulty establishing and maintaining relationships. In the restricted repetitive behaviors and interests domain, a child with autism may have difficulty with change, may have intense interests on certain topics, repetitive motor movements or repetitive speech, or their sensory processing might be different. So these are the criteria, but the main thing to remember is that everybody's autism looks different. And that's because each person may have different features of autism. Some may have more of one feature and less of another. And that's why we conceptualize autism as being on a spectrum, because of the wide range of manifestations that it presents with.
So Dan, we talked about mental health disorders being more common in individuals with autism. Which mental health disorders are we talking about that are more common?
Yes, as you mentioned earlier, Brad, ADHD and anxiety are the biggest ones. About a quarter of all children with autism have a co-occurring ADHD, and a large number, close to that same number, anxiety disorders. Many have a specific kind of anxiety manifest in phobias, fears of certain things, fears of bugs, fears of buzzing insects, high places or other things they're exposed to, and some just have generalized anxiety. Many children on the autism spectrum have sleep-wake disorders, as parents know that they have trouble getting to sleep, staying asleep, waking up in the morning. That's also probably about 20% of children have those. Also, conduct, impulse control disorder, behavior problems is a big one. And then about 9 to 11 to, depending on the study, 9 to 15% develop depressive disorders. Clinically, we see those often manifesting later, sort of in adolescence, as children begin to run into some of the hardships or struggles as their social skills come to light in teenage years or making the transition into young adulthood. Depression can set in, although it can come earlier too. Obsessive compulsive disorder is another one, not super common, but it does happen. Becoming obsessed and repetitive about certain things, and this is one that can be mistaken sometimes for between autism and OCD. Bipolar and schizophrenic disorder. So unfortunately, about 70% of children with autism have some kind of a co-occurring psychiatric or mental health problem.
So Dan, staying with you, do we have a insight as to why these disorders are more common?
Yes, we do have some insights. There are several characteristics of having autism that can kind of set up or make it more difficult to navigate the world that we live in, the society we live in. I think one thing that can be really difficult for children with autism is that our society and our world and school and the things they face are not necessarily really autism friendly. There's a lot of noise, there's a lot of competing demands. There's a lot of demand for social skills, and the social stressors can bring out some of the emotional problems that happen. A lot of stress around that happens. That can be an instigator of mental health problems, depression, and anxiety. Another one and that research is finding these days is that children with autism, on average, though not everybody, may tend to have emotion regulation deficits that might be kind of built into the way that autism is wired. And that means that having problems with getting really ramped up with emotion really easily, or getting stuck on certain things. And sometimes in the field, we call it brooding rumination. There's this tendency to kind of think about things over and over and over in a repetitive or negative way. And getting angrier and getting worked up easily. And then those can kind of set up a child for depression, anxiety, and some of the other things I've talked about.
So Amy, Dan has sort of set up a discussion around how these disorders start to interrupt everyday life. Can you expound on that? How do mental health disorders interrupt everyday life for individuals with autism?
Yes, just thinking a little bit about the main types of mental health disorders that we see, the most common ones: anxiety, depression, behavior concerns. A lot of children have periods of anxiety or depression, or they might have tantrums or behavior issues where they might refuse to do certain tasks. Sometimes this is just a natural part of life and child development. But they really start to become a significant problem when these issues start to interfere with the child's ability to complete daily routines, meet expectations at school, participate in family activities or social events that might be happening, or even learning independent living skills. For example, some children, when they become depressed, they might spend large portions of time alone, or if they're anxious, they might start refusing to go to school or interact with people that they need to in the community. Some children can also start to miss time in the classroom because they're being removed due to tantrums, or because of other behavior issues. They may not be able to join typical family life activities like, even going to a restaurant or doing enjoyable things that the family likes to do for fun. The other thing is that sometimes mental health issues can lead to safety concerns like suicidal thoughts, self-harm, aggressive behavior. And when these issues emerge, it's really important for parents to seek treatment immediately.
Dan, back to you. So is it challenging to identify or diagnose these disorders in children and adults with autism?
It can be challenging. It can be tough for several reasons. I mean, some of them related to what we've already talked about. Children with autism, on average, tend to have a little more difficulty expressing feelings, for one thing. Talking about how they feel, telling you that they feel depressed or anxious. They may show that more in actions than in words, and you kind of have to read the communication and behavior sometimes. A lot of times, children with autism have trouble reading emotions in others and knowing where they really should feel or how they should feel in comparison with others. So it's not as clear cut about what their emotional life is like underneath the behavior. And you can get easily caught up in the autism as a professional and as a parent or educator. You can think about the autism a lot, and that can overshadow some of the emotional and mental life of a child. And so you kind of maybe miss some of the emotional life. But other things can be that some tendencies that show themselves in autism, like becoming over aroused or doing repetitive things, or having trouble with sensory issues, they can be confused for certain kinds of mental health issues. So you might think it's anxiety, but it's really just autism. Or you might think that the child is just having autism when they're actually having a trauma reaction, but it kind of looks like autism. So that can be difficult. Another barrier is that most of our mental health work with children has been developed around typically developing kids. And so all our measures and scales and research has really not included autistic children very much. And so the measures that we have are really developed based on other people's reports about them or not including them at all. So we need to have better tools for assessing mental health problems in autism. And we also need to have tools that ask the child themselves how they feel so that they can have more of a say in their own voice about what their mental health concerns are.
Roma, Dan just a moment ago made the point about the sort of similarities of autism and anxiety. And we know that a common feature of both autism and anxiety is that they can both impact social interactions. For example, autistic individuals can have difficulty with different aspects of social communication, and anxiety can show up as social anxiety. So how do you think about the similarities and differences in how autism and anxiety impact social functioning?
Yeah, so both of these conditions, autism and social anxiety, affect the way a child or adolescent with autism engages with other people. And as Dan was saying and alluding to, that there's overlap in the symptoms. So it's hard to know sometimes what's autism and what's anxiety, what's social anxiety in particular. The common features between the two, whether you have autism or whether you have social anxiety, is a tendency to avoid talking to people, just showing less interest in wanting to be with others, perhaps avoiding social situations, making less eye contact. Young children might run away and hide. There's a general, I don't want to interact kind of feeling. The differences between the two, though, are the underlying reasons why the person doesn't want to interact. And in autism, the reason is about preference. It's not something that a person with autism may primarily enjoy. They might rather be doing something else that's more interesting to them. They might also have difficulty understanding social cues, or as Dan was mentioning, learning how to identify and express feelings. So it's more of a preference, some difficulty with social understanding. In social anxiety, the reason for not wanting to interact is not because of preference, but it's because the child is anxious. So people who have social anxiety, they usually want to try to engage with people, and they do usually have a social understanding of the back and forth of conversation. But what they're worried about is that if they say or do something, which they, might be perceived as dumb, and that other people will laugh at them and that they will be judged. So it's about how other people perceive them in social anxiety. So very different reasons. And I want to emphasize that a person with autism can have both autism and social anxiety. And so you don't want to miss the anxiety part. And that when you have social anxiety on top of autism, it can increase all of the autism symptoms. They just become more pronounced.
Amy, let's talk a bit about intervention. Cognitive behavioral therapy is effective for anxiety disorders. What is cognitive behavioral therapy, and in what way is it effective for anxiety disorders, both in individuals with and without autism?
Yes, so cognitive behavioral therapy, or CBT as sometimes we refer to it, is an extremely well-researched treatment approach. It was originally developed for non-autistic adults and children, starting with people with anxiety, although it has been expanded to other mental health conditions. But the main focus of CBT is to teach people new ways of responding to distressing thoughts and emotions that accompany mental health conditions. About 15 years ago, autism researchers began to look in ways that they could modify CBT approaches to specifically treat anxiety in autistic children. And what these treatments involve is very similar both in autistic and non-autistic children. It really focuses on teaching children to recognize body cues indicating that they're anxious, spend some time noticing differences in the levels of anxiety that they may experience. They teach them relaxation strategies to help manage some of those uncomfortable feelings that can go along with anxiety. Teach them ways to modify worried thoughts and other types of anxious thoughts that can make the anxiety worse. And then there's a really big focus on helping them face the things that they're afraid of. So really facing triggers for their fears. That's called exposure, and it's a big part of CBT. These approaches are the same between autistic and non-autistic children, but we also have some modifications and ways that we utilize the strategies to be really effective with autistic children. For example, we might spend a little bit more time on some of the behavioral strategies and a little bit less time on some of the cognitive restructuring, changing the thoughts, because sometimes kids respond a little bit better with autism. They respond a little better to the behavioral strategies. Now, while there's a lot of research supporting the efficacy of CBT to treat anxiety in autistic children, there are some limitations to this research. So most of these studies have focused on children who are 8 to about 16 years of age and have included children who do not have language or cognitive delays. So unfortunately, these strategies are not yet readily available and known to be effective in all autistic children. But the good news is that there are a number of research groups who are working actively to modify these approaches, both for younger children, older children, and children with developmental delays. So the work is emerging, and I think it's promising that more intervention options will be available for the full range of children.
Amy, are there other types of evidence-based or research-supported treatments for individuals with autism?
Yes, there are two other main types of mental health treatments that have been supportive in the research literature for autistic children. Probably the one that's the most well-known are behavioral therapies. So these are sort of cousins to cognitive behavioral therapy, but some of the differences are they tend to focus more on training parents to use specific strategies that help to reduce behaviors that interfere in the child's life and the family's life. They tend to focus on things like tantrums or aggressive behavior and looking at ways to reduce both of those. In these approaches, the mental health providers help parents make changes to the child's environment to help prevent behaviors, and also help parents change how they, and other providers, caregivers, and teachers, how they may respond to the behaviors that also reduces their frequency. And then the other type of intervention approach that's been well researched are more executive functioning approaches that are really focused on teaching children and parents strategies to help them learn how to solve problems, increase their flexibility when they're facing social situations. So they might consider a variety of responses as opposed to maybe getting stuck on just one way of responding. And there also can be some work just teaching them general emotion regulation strategies that are embedded in this. So really hoping teaching them some of the strategies they need to be effective in daily life.
Hey, Luke, bringing you into the conversation. Sorry for the long wait. Can you comment on, is there promising research on new interventions on the precipice?
Sure. So really over the last decade or so, myself and Dr. Roma Vasa, who's with us today, have been conducting research on mental health crises in children with autism. In fact, we've developed a measure and a definition for what constitutes a mental health crisis. We define it as two things. One is there must be the presence of an acute psychiatric symptom, things like behavioral challenges, which we've heard about today, but other things that are common like elopement or running away in scenarios, especially in the community. The second part is there is a lack of resources to manage those behaviors. What's important is we see two different scenarios frequently. We'll see a child that may have serious behaviors, but the family is very well organized or very well resourced to manage those behaviors, and the crisis can be managed. But on the other side, there are families that are struggling or not well resourced to manage the child, even if the behaviors are not that acute. Our research estimates that about 20 to 30% of children are at risk for a mental health crisis in the last 3 months. And sadly, we see the product of crises frequently in the news and media. We hear stories about children languishing in emergency departments and fatal interactions with police officers. Part of the reason is the field is really focused on reactive and often restrictive approaches to managing mental health crises, like sending a child to the psychiatric emergency department or an inpatient hospitalization. And so our work is really focused on prevention and trying to get there before a crisis occurs. And so we recently completed a randomized trial of a new parent-based intervention to prevent the occurrence of a mental health crisis. We found it was safe, it was feasible. Families were extremely satisfied with this program where they worked alongside one of our social workers here at Kennedy Krieger. And families felt like they were much better prepared to manage their child's behavior. So today we're working on publishing those studies and making them available to families.
Excellent. So along these lines of mental health crises, Roma, somewhat alarmingly, suicide rates are 5 times higher in autistic individuals compared to people who don't have autism. How are we understanding and importantly addressing this issue?
This is a very serious problem, Brad. Now that we know that autistic youth have elevated rates of suicide, this has become a top priority in our field. And the main strategy is prevention, prevention, prevention. Every suicide is preventable with the right support at the right time. So in terms of helping autistic individuals, what are the prevention efforts that are underway? So first is just disseminating this knowledge. Not all clinicians in the mental health and medical field are aware of this heightened risk of suicidal thoughts and behaviors in autistic youth. So we need to spread that word. Second, we're making efforts to routinely screen for suicide in autistic children and adolescents across all clinical settings. So not only mental health, but medical clinics, the emergency departments, inpatient medical hospitalization settings. And this is what we're doing at Kennedy Krieger and Johns Hopkins, emphasis on screening. We're also developing new suicide screening measures, as Dan was saying. Most of the measures that we have are for children without autism. And so we're developing new suicide screening measures that are tailored to children with autism. They're clear, understandable. They allow an autistic individual some time to process and respond to questions. Yet they ask about suicide in a very direct way. We don't beat around the bush. We get right to the questions. We're educating parents about signs and symptoms to look for, to note that their child is struggling. And we're working with children and families to develop safety plans. What do you do if you start experiencing distress or have suicidal thoughts? And last, as a field, we are trying to develop new treatments. So the treatments are not only for acute suicidal thoughts and behaviors, but the treatments are to help individuals cope with strong, intense feelings. If we can find constructive and safe ways to help them cope, rather than resorting to suicide to make that feeling go away, we're going to be able to prevent suicidal thoughts and behaviors and improve mental health outcomes.
Dan, you work with some autistic children who are non-speaking. How do you go about assessing and treating a child who is not communicating with you verbally?
Well, I won't say that we are any kind of experts in working with children who are non-speaking, but we get presented with non-speaking youth who obviously have behavioral or emotional problems. And so we do our best to address that. And let me just name a couple of ways we do that. One way is that we rely a lot as partners with parents and caregivers, because they are always, they're the expert on their child, and they know, they can read the signs usually really well and tell if something's going on. So we listen carefully to what they say. We'll often take, in assessment, we'll take a big picture approach and kind of look at the whole life history, look at the events of the child's life, and look at the changes that have happened that may be indicating a mental health concern. For example, a parent may report that a child with autism who's non-speaking may have started to be more withdrawn, more anxious, not enjoying the things they used to enjoy. And then we may be able to trace that to some evidence that there's depression there or something, and that can lead us to help understand better that there may be a mental health concern or avoidance in the case of some anxiety or trauma. So one thing is to work with the parents and to get a timeline. Another one is that many of the children who are non-speaking understand receptively pretty well what's going on around them. They just don't have the words to express it, and they're expressing things behaviorally, but they're not speaking so much. So we are developing and working on assessment tools using electronic devices like a tablet or apps where the child can have a multimodal presentation of questions about the emotions. For example, do you feel like this? Do you enjoy things like you used to? Has anything happened to you? And the child can answer by touching a screen and not have to verbally answer. And then we can score those much like we might score another instrument for a speaking child and get some clue about whether there's a mental health concern underlying. And then our treatments may be much the same way. We will sometimes use speech aids or devices that the child is using for communication as part of our therapy. And we work very much through the family and the parents to help as an interpreter, as a mediator, and help educate parents so that they know, and caregivers so that they know more what to look for in a child who has, and how to kind of make some interventions to help them feel better. So it's not a perfect science, but we're working on it.
Understood. You know, in the introductions, I mentioned that you're in our Center for Child and Family Traumatic Stress. You're also an expert in trauma in children, including those with intellectual disability. How do you, as a clinician, how do you know when a child is having a trauma response, a traumatic reaction, if they're unable to communicate what's going on, and how do you ascertain it, and also the approach to treatment?
For one thing, we know from the research data that exists that children with autism are roughly double or more likely than typically developing children to have potentially traumatic events in their lives. Maltreatment, abuse, bullying, and restraints are just some of the things that they encounter. They encounter them more than typically developing children. And yet our treatments and our assessment tools are way behind the ball as compared to children who are typically developing. And so we're working on that. Some of the ways we can know are the things that I mentioned for assessing mental health broadly. If we know that there's been a traumatic event, many times we can look at the timeline and the life experience of the child and look for shifts or changes. there is some research evidence now that suggests that many children with autism, when they've encountered a trauma, they show some regressions in previously developed abilities. They may lose speech they once had. They may revert to stereotypical behaviors they used to have, or toileting concerns or other things following an event that's potentially traumatic, and that can help give us some clues. Another thing that we can do is to use our interactive trauma scale that we've developed, which is an app, as I mentioned earlier, so that the child can respond to a touch screen and help make some self-reports about their experiences. You know, it's really interesting if you know autistic children who are nonverbal, many of them carry a tablet around and are very adept at using it. And we want to take advantage of that same interest and engagement and understanding to help understand trauma and mental health concerns in these children.
Luke, let's shift to talking about sort of public health. You're a public health person, but let's talk about some of the challenges that families face in access to care, seeking care, and getting access to care.
Sure. So access to care has been an issue in autism really since the beginning. Unfortunately, there has not been an adequate number of mental health providers that have been trained in autism. It requires an extra level of training beyond people's normal training. And fortunately, we have specialized like psychiatry programs here at Kennedy Krieger Institute and also our affiliate Johns Hopkins that do that type of training. But it's still not enough. And we see that in the numbers. So only about 13% of mental health facilities in the entire United States have a provider on hand that can see a child with autism. And this has translated to parents reporting that they're having difficulty accessing care as of today. So recent estimates suggest that about 20% of families who have a child with autism report that it is very difficult to nearly impossible to receive any type of mental health care for their child because there's just not enough providers.
So what is broadly, what is currently being done to improve access, in particular to mental health services for individuals with autism?
Yeah. So we really need to expand workforce training. I mean, I think that's really the solution, but that's still going to be really challenging because we have higher numbers of, prevalence is increasing and it's not keeping up with the number of people going into the field, much less the number of programs that are training providers. So there's really two programs out there, I think, that are of value and interest. So one is called the ECHO model, and ECHO has become really popular. And this is a way to create kind of a learning community to train up other providers that don't have specialty in autism. And you can see that with pediatricians, right? So pediatricians are really the first line, I think, of provider that are seeing children with autism out in the community when there's not specialized facilities. In Baltimore, we're fortunate to have Kennedy, and people actually move here just to get access to Kennedy's services. But everybody else across the country frequently doesn't have a specialized center. So ECHO does this telehealth model where they bring in these providers and they do training and active activities with specialists in autism to provide them different vignettes and scenarios to really provide that support and specialty experience. One challenge with ECHO, though, is the benefits, the trickle-down benefits. There's been some data from clinical trials showing that it might not be as clear when you train a general provider. And so I'm working currently on expanding a model called the collaborative care model. And this is a very old model that's been used in many, many, many different fields in PTSD and bipolar disorder and depression. And the whole idea is to bring in a team, a clinical team, to work with like a pediatrician or a primary care provider. And the idea is this team actually jointly treats the child or the individual that has a mental health challenge. And by getting access to that team, you can get a psychiatrist and a therapist, and you can serve many, many different children and many different people with a smaller team. And once that child reaches clinical stability, so there's lots of measurement, and really importantly is there's a service coordinator. And this is a person that keeps all of the treatment together. Because we know that one major challenge for families is the mental health system is really complex. And dealing with all of the different referrals can make it really hard, and then staying in care long-term, especially for under-resourced families is challenging as well. So this model wraps the family up, and when the child gets stable clinically, then they move on. And it's a really great public health model that nobody surprisingly has done before in autism, and we're hopefully the first that are going to do it.
So Roma, let's go back to therapy, and you're a psychiatrist. Let's talk about the use of medications. In what way are medications used as well as, or in addition to, or instead of behavioral therapies to treat the psychiatric and behavioral conditions that we're talking about today?
So we do sometimes prescribe medications for mental health conditions. There has to be clear indications, right? So we want medications to be part of the treatment plan, but we usually reserve medications for when the mental health condition is moderate to severe, and we think therapy alone will not be sufficient to address the problem, but taking a more combined approach of medication and therapy might be beneficial. And in fact, in our clinical trials in non-autistic children for anxiety, for depression, for other conditions, the data show that combined medication and therapy approaches are superior to either medication alone or therapy alone. In autism, there are currently 2 medications that have been approved by the Food and Drug Administration for behavioral symptoms. They are risperidone and aripiprazole. And the indications for these medications are irritability, aggression, and self-injurious behaviors. So these medications can be very helpful. They are reserved for children who are having significant behavioral challenges that are interfering with functioning, perhaps going to result in a more restrictive school placement. Perhaps the behaviors are causing injury to themselves or others. They can be very helpful, but they do have significant side effects. And so they require close monitoring by the professional who is prescribing. Other medications that we use for children with autism, all other medications we don't have any FDA indication for, but we know many medication classes are effective in children without autism, so we try them for children with autism. So medications such as psychostimulants, brand names like Ritalin and Adderall can be helpful for ADHD type symptoms. Medications such as antidepressants and anti-anxiety medications that we use in non-autistic children could potentially be helpful. We use different mood stabilizers for emotional or behavioral dysregulation. When prescribing, we always start with the lowest dose. We increase very slowly, and the reason is because the data have told us that children with autism are more sensitive to medicines and are more likely to have side effects. So we may not start with the regular dose that we do in somebody who doesn't have autism. And we take many factors into consideration when selecting the medicine that we're going to prescribe. One thing I always tell families when thinking about treating mental health conditions is that medications are often one spoke in the wheel. We always need to think about therapies, stabilizing medical issues, which can aggravate things like anxiety and aggression. We need to address stressors, life stressors, communication, and also just generally thinking about healthy lifestyle patterns. So regular sleep, diet, movement, and physical activity. And, this wheel is very, it encompasses many facets of treatment. But that's how we're going to maximize the outcome. And the wheel is going to look different for each child because there's not one wheel, there's not one size that fits every child. It needs to be personalized to each individual in terms of the type of medicine, the type of therapy, and the types of supports that the child will need.
Amy, earlier in your comments, you made the point that there are situations where there's the need to urgently seek attention. So what are the signs or symptoms of a mental health concern that should parents, teachers, or other caregivers really attending to, who are autistic so they understand when they need to urgently seek care? And are those signs different or the same for children who are typically developing?
Yes, so sometimes the signs of mental health concerns in autistic children can look very much the same as what we see in non-autistic children. So we think about signs of significant emotional distress, frequent sadness, crying episodes, frequent irritability, severe anxiety that's causing interference in daily life. We also want to look for change in functioning. So the child no longer engaging in positive behaviors they did in the past. And also just significantly interfering behaviors like tantrums and aggressive behaviors. And then certainly if a parent or a caregiver were to hear of suicidal thoughts or see significant dysregulation, that would be a sign that there is definitely a mental health concern that should be considered. But as a number of the presenters have already mentioned, sometimes autistic children have a hard time expressing their emotions and their thoughts. And so therefore the signs of mental health concerns can be a little bit more difficult to detect. So parents often have to think more about watching for changes in the child's specific behaviors and maybe their functioning patterns. So, oftentimes autistic children may not be quite as socially engaged or spend quite as much time with people as a non-autistic child. But if a parent were to see increased withdrawal, so the child is spending even more time alone, or they're stopping to participate, they're no longer participating in daily activities, or they're showing more behavioral escalations than are typical, that could be a concern. Sometimes we also see more repetitive behaviors like increased repetitive motor mannerisms, greater difficulty tolerating changes, increased focus on specific interests, particularly sometimes if they're about more kind of morbid or darker themes. And I think as also Dan mentioned, sometimes there can also be a regression in functioning. These can be some signs that there could be a mental health condition present, and that consulting with a primary care physician or mental health provider is a good idea.
Roma, back to the topic of crisis, if a child or adult with autism is having a mental health episode or crisis, what steps should the family take?
So as Luke was mentioning, mental health crises are very serious and they're very difficult situations. They have devastating impacts on the child and the family and perhaps others in the environment. Children with autism who have moderate to severe mental health conditions are always going to be at risk for crisis. And as we've been talking about here, the best way to address crisis is prevention, right? So I know access is really difficult, access to care, but even when a child first starts showing signs of anxiety or signs of behavioral problems, even when it's mild, really just get connected to mental health resources, therapy, and psychiatric care. And the other aspect of prevention is working with parents to develop just an emergency plan, right? What will we do if our child has a crisis? Whether it be, and having the parents work with professionals to develop that plan. Will it be to implement a specific behavioral intervention? Will it be to just create a calm, safe space until the child calms down and de-escalates? Will it be to give an extra dose of their medication or give a comforting object, a toy? Or will it be calling 911 or taking the child to an urgent care center? I always encourage families of children who have moderate severity psychiatric concerns to be familiar with their local emergency department, the inpatient hospital, and law enforcement to just know how much they're tailoring their care for autistic children and that they have an autistic child. And hopefully they'll never, ever have to engage with these services, but at least they know they're available. Now, I think the dilemma occurs is that when a crisis occurs, the question that enters a parent's mind is, should I take my child to the emergency department? And that's a really tough decision. Clearly, when there are concerns about safety, the most important priority is to keep the child safe. And going to an urgent care center or the emergency department, as recommended by their professional, is the best option we have right now. I want to acknowledge that I know the emergency department experience can be hard, right? Emergency departments are loud, unpredictable. Families have to wait a long time to be seen. Clinicians may not be familiar with how best to support autistic children. I think the best thing that parents can do is share as much information as possible with the providers there about how best to support their child and give them a safe, calming space in the emergency department, and work collaboratively with the team to provide gentle, humanistic care while the child has to be there.
Let's talk about family a bit. We know that the siblings of children with autism are at greater risk for an autism diagnosis. What about the risk for these co-occurring mental health disorders?
Yeah, so this is really about genetics, which is at play. And since children with autism have an increased likelihood of having a co-occurring mental health condition, their siblings will as well. And it's also likely that the parents do as well. So if anyone in the family has a particular condition, anyone that's biologically related to that individual is at increased probability as well. But importantly, genetics are not a crystal ball. They are not fully predictive. So it doesn't mean that another person is guaranteed to have that condition. So importantly, you can watch, and if you see particular symptoms, especially if they're causing problems, we recommend you talking to your doctor, to your child's doctor. And your child's pediatrician can do screenings, and there's really good measures out there for identifying whether there's symptoms and making referrals or providing treatment as necessary.
So Dan, along the theme of family, having a family member with autism and mental health challenges can certainly be a stressor for the entire family. How do you characterize services or approaches that can help the entire family system?
What I will say is that the families that we work with who have children who have autism, by and large, they are, wholeheartedly devoted to their kids, and are fierce advocates for them in many cases. But, they're often experiencing a lot of stress, as you mentioned. There's the genetic aspects of it that, as Luke mentioned, but also there are what we call, the burden of care, the emotional burden that it constitutes caring for a child who has struggles. And there's a literature called the adverse child experiences literature in the science world about how exposure to certain things like mental health problems in the family and poverty and exposure to community violence and racial discrimination and all those things can take a toll on a person across a long time. And one of those things that can be adverse is taking care of a child with a disability. So there's that emotional burden that I talked about. Some ways to help with that is some of the therapies we've talked about. We really recommend oftentimes that families have another therapist, like a family therapist or someone to see the parents. I'll say too that the divorce rates are higher, and also the rates of emotional illness in parents is higher because of the stress, and they can often benefit from that extra care. The siblings often will be in a role, sometimes get in a role of a caregiver role, or they get anxious about the worry about someday needing to take over care of that autistic sibling. And that takes a toll, even though it might be quiet. A lot of times there's a lot of attention to the child with autism by necessity, and then the other family members don't feel like they get as much attention. So that needs to be addressed. And fortunately, we can do that sometimes in our therapies. There are also some good supportive groups, especially within autism societies. So the Baltimore Autism Society, Autism Society of Delaware, and others can often help families get connected with other families, can be very helpful. And resources for things like respite care. so that the family might have some help with looking after an autistic child, and things like that that can help support a family through some of these stresses and burdens.
Amy, we know that autistic people very often have outstanding strengths and skills. What is meant by a strengths-based approach to care?
There's a growing movement to develop mental health strategies that really focus on identifying a person's individual strengths and then capitalizing on those to address the person's mental health needs. For example, the way this might be utilized with autistic children would be to help focus on, thinking about their focused interests and the fact that oftentimes these interests can provide a lot of pleasure and sense of well-being. Under a strength-based approach, a therapist may teach the child how to use that interest to really reduce feelings of anxiety or sadness. They also might really focus on helping an autistic child who has a real strength with technological expertise to use this as a way to connect with others at school and in the community. Another really important part of strength-based approaches that I think is particularly pertinent to autistic children is helping them really to accept themselves fully and validate the strengths and the skills that can accompany autism. Sometimes in the therapeutic setting, this might start as providing, just teaching the child about autism. Maybe they haven't had a lot of that instruction already. They may not know a lot about autism, helping them then learn how that may apply to themselves and their own personal strengths. It can also involve really teaching them what they may need to feel comfortable, accepted, and valued, because sometimes children need a little help to kind of figure that out for themselves. And then the next part of that would really be teaching them how to advocate for these things, within their families and their schools and their communities. There's increasing research at looking at strength-based approaches, both as sort of standalone treatments and also as ways to modify existing treatments like CBT and other interventions that we're using with autistic children.
You might not be surprised to learn, Dan, Amy, Luke, and Roma, that there's an enormous number of excellent questions that have come up in the Q&A in the chat. So I hope you don't have any plans for the rest of the evening, because I think there's a large number of really excellent, sophisticated questions. So let's start to dive in. And for the audience, we'll try to get to as many of these questions as time will allow. And okay, let's dive right in. So Roma, the first one is for you. It's a question about antidepressants. Do certain antidepressants work differently in kids with autism versus the general public?
So the mechanism of action of the antidepressants is the same, whether you have autism or whether you don't have autism. In the class, there's many different classes of antidepressants, and the types of antidepressants that we usually first start with are the ones that target serotonin. They're called selective serotonin reuptake inhibitors, or SSRIs. And these are medications by brand name that, include Zoloft and Prozac and Lexapro and Celexa. They work slightly differently in autism in one way that we know about so far, and that is that kids with autism are more sensitive to this class of medications. They have a higher rate of side effects. And one particular side effect that we see that is of most concern is something called behavioral activation. And that is when kids become, instead of the antidepressant calming them and having therapeutic benefit on relieving anxiety and improving mood, it actually agitates them. And so it makes children more irritable, aggressive, hyper. Maybe they might have sleep problems. And this risk, we have learned, is there with every potential dose increase with this class of medicines. So when we prescribe these medicines, we always start low, we increase very slowly, and we always discuss a plan for what to do should this side effect occur.
Amy, this question comes from a parent of an autistic son who's 6 and has recently regressed in his toileting. Do we see this, and what can be done to help?
Yes, that can happen for a number of reasons. Sometimes it could be a sign of maybe just stress and other things going on in the child's life. Sometimes it could just be a result of changes in the child and maybe needing to reinforce some previously learned behavioral strategies. Behavioral therapists have lots of different ways of approaching that and ways of reinforcing that skill. And so working with a behavioral therapist to develop some strategies and behavioral techniques to address that would probably be useful.
Luke, this one's for you. It's a question about the COVID era. Since COVID, has there been an increase in the need for evaluation for autism, and has there been more diagnoses linked to the COVID era? And did the level of social isolation have any impact on kids who are on the autism spectrum?
So there's two questions in there. One is the impact of COVID on diagnosis. And the answer is it's actually exacerbated or made the waits longer. And so the reason why actually we published a study recently on this is a lot of the evaluations that are done require face-to-face interactions, often using something called the Autism Diagnostic Observation Schedule. And when those face-to-face interactions did not occur, providers were more uncertain and they did not give the label of autism. So that means the child had to come back and get reevaluated to then get the diagnosis of autism, creating further delays. So that's problematic. Has the pandemic made concerns about social isolation and exacerbated autism? Is that the second question?
Yes.
Yes. I don't know if it's actually exacerbated autism in and of itself, but it's certainly complicated because we've been talking about mental health conditions. And so myself and Dr. Vasa and a variety of other people have published a number of studies showing that mental health symptoms got worse, both among the child, but also the parents as well during the COVID-19 pandemic. And I think what we see is there's residual effects of the pandemic that are still existing among people, and they're still trying to recoup. And so it certainly has not made anything better, for sure.
I might jump in here if I could. I know that's the case. I wouldn't deny that kids really struggled with the pandemic, although there have been some studies in some of our clinical experience that some children during the pandemic were at home and their stress was quite reduced, and they reported feeling not much worse or not worse at all in the pandemic. So I guess there were probably mixed responses in some ways.
So Luke, back to you. The query is I would like information specifically about autistic children of color and how this additional factor has an impact on mental health per se. Maybe we could talk about also recent updates in the CDC prevalence rates as it relates to people from underrepresented groups.
Sure. So there's two questions in there. One is the autism prevalence. So really in all the years the CDC has been tracking the prevalence of autism, whites or Caucasians are more likely to be diagnosed with autism than any other racial or ethnic group until actually about 5 years ago. And for the first time ever, we saw a closing to now the prevalence estimates are the same among Black African Americans and whites. We still see a delay actually among Hispanic populations as well. So that's an area that still needs improvement. But that's really great because what we're seeing is more equity in diagnosis. But what we're still seeing a delay in is time to diagnosis. So there's still a delay there. In terms of mental health care access, we see still more disparities in Hispanic populations, actually. And African Americans, there's likely still there's certainly less providers in areas serving Black people, and certainly less providers that are trained to serve the specific needs of Black and African American families. But in terms of actual co-occurring mental health diagnoses, I think it's actually equitable or equivalent among the two populations, whites and Blacks.
Amy, I think this one is best for you, but you all correct me if I'm wrong. So the question is, or the request is to please address avoidance attachment and the most effective treatment strategies for BCBAs or other therapists.
Yeah, I'll encourage my other group members to join in as well. So Yes, I think in terms of I guess it's maybe talking about relationships with parents, with their, yeah, a lot of BCBAs, I'm not sure that that's the type of work they're doing, although I think certainly thinking about the parent relationship is really important. I definitely think in terms of just promoting positive parent-child interactions, that's an important part of any treatment program for autistic children. And I don't know if there's also discussion there around just sort of avoidance in general of other positive experiences. I think that's another part that's an important part of treatment, particularly if there's an anxiety component at play.
Roma, is there any, or Amy, is there any research around neurofeedback therapy for teens with autism?
There aren't any studies that are currently underway in terms of neurofeedback. A lot of new and exciting therapies underway, a lot of third wave therapies, mindfulness, relaxation training, breathing, movement-based yoga, Tai Chi. These are all excellent treatments, but not quite neurofeedback.
Right. Sticking with you, Roma, the topic is self-harm, or for example, cutting. Is there research showing prevalence or increased risk of that behavior for autistic teens?
Yeah, so autistic teens can engage in kind of self-cutting, deliberate self-harm behaviors, and those are also occurring at higher rates than in non-autistic children. And I think one of the main reasons that is driving that is that, when cutting and deliberate self-harm is a means to kind of just release negative emotions. It provides calming, it's a discharge, and we know that mental health conditions, emotional conditions, depression, anxiety, anger, irritability are all built up. They all easily build up, especially across different contexts. As teenagers get older, that social landscape becomes more and more complicated. Some are working much harder to try to fit in. They kind of hold it in all day, come home, release it, and that could increase risk for these kinds of self-harming behaviors.
Amy, are there, let's see, are there specific resources that you can recommend for early intervention providers, to identify early intervention providers? And if so, where can we access them? And that reminds me, when we compile this and record it, we can also attach resources to be made available as well. So early intervention providers, how can we find them?
I'm sorry, it's the question about how to find early intervention. So, I think probably the best place to start is thinking in terms of state provided services. The infants and toddlers and child find programs in Maryland, as well as in other states across the country, are really quite excellent, offer fabulous evaluation and treatment services, sometimes even offered in the home. I think that's a great place for providers family members to start if they're concerned about developmental delays or autism. And then they can often be a great resource for connecting families to other types of more private or community-based organizations if that's needed.
I think let's have Dan and Roma chime in on this one. Are there any services for autistic adults for mental health and medical management to help with impulse control and aggression? Adult services. It's a tough one, I know.
Dan, do you want to start?
I'm less familiar with the adult autism world, but I know there are services, but they are admittedly few and far between. And I think this is one of those areas where we have a workforce limitation, where I think the field is working on making sure that we have well-trained providers who are versed in how to help autistic adults manage behavior and manage these kinds of difficulties.
And I would just echo what Dan said. Finding services for children and adolescents is tough. I've heard parents say it's sort of like falling off the cliff when the child becomes an adult, because there are such a scarcity of services
Yeah, and
for that group.
picking up on what Luke said earlier about Project Echo, we need to implement capacity building approaches because we're not going to train our way into providing the level of service necessary in a prompt fashion. So capacity building is key. I think the topic of sleep and exacerbation of anxiety, we touched on earlier, I think, but let's talk some more about how one can help their child with sleep-wake disorders that can exacerbate anxiety and is more likely to be present in children with autism. Who wants to take that one? Amy?
And just get the ball rolling because this is, I think, a pretty complex topic. We know that sleep issues can be very multifactorial. There can be behavioral components, there can be medical components, sensory autism related components. So, I think what we usually encourage parents to do is start with some of the basics, like thinking about sleep hygiene, making sure you have a really regular bedtime routine. You're avoiding issues or substances that might cause your child to have difficulty sleeping, reducing screen time. But sometimes these sorts of things are not enough. And when that's the case, we often will recommend a multidisciplinary evaluation to really get at the root of what's going on for the child.
Can I chime in for a second?
Please.
So my doctoral student of mine and myself just published a study on something called social jet lag, which is one of my favorite terms. And this is when we stay up later on the weekends. And so we did an evaluation of children who had sleep patterns that fluctuated on the weekends, but then returned to baseline during the week. And we found that there was actually residual cognitive deficits. So children were academically and cognitively testing lower when they had disrupted sleep cycles on the weekends, because the term social jet lag is if we're out, doing something social. But either way, it's keeping that consistent natural rhythm in sleep is really important.
So Roma, this is, I think, a really important question to get at. The question is speech regression, speech or language regression, quote unquote, normal in kids with autism?
Any type of regression should always be taken very seriously, and never assumed to be normal without further evaluation. And certainly everybody has off days, but if there is a pervasive pattern and a parent notices that the child's language is not at the level that it should be, that requires immediate intervention, immediate evaluation, looking for regression in other domains of functioning. There are, in the developmental unfolding of autism, there are time periods where a child's developmental milestones will have regressed. And one of those times is in early childhood. But we know that regression can also occur at other time periods throughout the lifespan. So again, any type of regression, I think, requires immediate evaluation.
Roma, sticking with you, do we have specialists? I guess the question is for Kennedy Krieger, do we have specialists that can evaluate hearing function for a nonverbal child?
So we have a wonderful department of audiology here at Kennedy Krieger. The experts there are really skilled, knowledgeable in hearing impairments in children with developmental disabilities, and really take a wonderful, careful, sensitive approach to diagnosing these conditions. And hearing, even without hearing impairment, a hearing evaluation should always be in the diagnostic workup of children with autism.
100%. Dan, this one's for you. How is the interactive trauma app or other assessments presented to individuals who are non-readers?
It's read to them. So the verbal content of it is kind of presented in a multimodal way. There are kind of simple wording that's on the each screen in question, and then there's a voiceover to read that. And we're working on being able to translate that into other languages besides English and ASL, so they can see the graphic design, read the content, those who can read, and have it read to them out loud.
Here's a very practical kind of question. I'm sure this will be related to by many on this call. I think Amy, how can I make sure my son's teachers are making sure he uses the restroom? He gets hyper-focused and will have accidents. At home, we use timers and we're successful, but at school, he has accidents. How do we address that?
Yeah, I think the first thing I would suggest is definitely having a meeting with the child's IEP team to discuss this concern. Thinking about ways to build in regular, very routine times throughout the day that the child will be taken to the restroom to make sure that that doesn't happen. That can be certainly added as part of the IEP to make it official. It even could be part of a behavior intervention plan if the parent wanted to request that be the case. I think sometimes there's definitely an education piece that comes to that as well, and making sure that the teachers really kind of understand what the child's needs are, and also examining if potentially additional supports are needed in the classroom. If perhaps there's not, if the teacher is just overwhelmed with the number of students and there's not enough individualized support, maybe that would also need to be something that's examined for the student.
We've been talking about autism and co-occurring mental health conditions, but of course, individuals can also have complex medical conditions in tow. And so the question is, do you have any advice for an autistic teen who has anxiety, but also has serious medical issues that cannot be easily resolved? Roma?
My main advice would be to make sure there is a team of professionals, of specialists wrapped around the care of that individual. There is, the mind and body are connected. And so there is going to be an interaction between the mental health and the medical, and one will exacerbate the other. GI symptoms will exacerbate mental health problems, vice versa. So this really requires a multidisciplinary approach with a lot of coordination amongst the professionals. When you have somebody with such complex, what we call comorbidity, more than one condition, you can't work in isolation, because if I see an increase in mental health problems, I can't be absolutely sure they're solely due to the mental health issues. There may be a complicating medical issue that's driving the increase in mental health symptoms.
And from a therapist approach, I would add that this isn't that unusual a situation that kids with autism have multiple concerns, eating and GI problems and pain, as well as anxiety and other things. And so I think the therapeutic approach to that would be, and it's fairly effective in many cases, kind of CBT approaches to helping them understand their pain, mindfulness and movement techniques, and exposure therapy for trauma and all the anxiety that goes with those things. So as Roma's saying, if we can work together as a team, we can often help provide those kind of wraparound solutions.
Luke, let's talk about emergency services. Are there emergency service providers who are specifically trained for individuals with autism and having a mental health crisis?
So unfortunately, there aren't enough. So I would say there's two things going on nationally that are important. So one is police and emergency responders are being trained more and more often. And there's specialty mental health units, which partly include some training around autism. So that's really important, is that mental health providers, police and emergency responders are prepared. Second is there are some emergency departments across the United States. I know Johns Hopkins has a variety of different initiatives taking place to make the emergency department more accessible. It's becoming very common to see a child with autism, not only for mental health, but just for medical issues. They have medical complexity that needs to be served, and it still needs to be an adapted environment. And third is, for many years, I've been doing research on the START program, and this is a national program that's in, I think, 13 different states that provides crisis care for children and adults with autism and intellectual disability. And we've demonstrated that there's been significant clinical improvements with that program. So there are efforts going on. Certainly more needs to occur.
There's a lot of questions that are generally around the theme of access to adult services. I think we've talked about this a bunch. I mean, in general, we've acknowledged that there's really not sufficient numbers of adult providers to take transition of care, to make a diagnosis, perhaps in a person who has grown up without having been evaluated. So I'm just acknowledging that that is a theme that's running through many of the questions I'm seeing. Let's talk a bit more about regression. So a number of questions have come up about the phenomenon of regression, especially around puberty. So Dan or Roma, maybe talk about the phenomenon of regression and how to think about it. Why we talked about, Roma mentioned periods where you tend to see regression. What's special about puberty that makes regression more likely for some?
Well, puberty is a time where there's just so many changes in the body and the brain happening, right? The brain is reorganizing again. And the body is developing, kind of morphing into an adult body. And you see a powerful effect of hormones, which is really just one kind of factor that could be implicated in regression at that time. There's also an enormous amount of stress that adolescents experience around the time of puberty. They're going into middle school, some going into high school. So you've got the effects of stress, adverse experiences, as well as neurobiological and physical changes. And there are other contributing factors. And during that time, I think we can see regression in milestones. We can see regression in mental health conditions, right? They can deteriorate and get worse. And sometimes the regression can be very severe and result in a state of what we call catatonia, in which the mental health conditions have severely deteriorated and the body's now in a completely different motor kind of a state. And it's a really vulnerable time, that transition time. It's very, very vulnerable. So I think it's really important to be working with professionals going into puberty before a child enters that time, to really understand the complexity of experiences that could potentially result.
And I might note, just from our clinical perspective, is that many times, at least in my experience, young kids with autism can be somewhat oblivious, in terms of how difficult things are in the world and social settings. And as they get older, there's this pattern of the light turning on and realizing, oh, I'm not where I thought I was, and I'm comparing myself, and I've got all these demands, as Roma's mentioning too. The demands increase a lot, and then they increase again, and when they, and they cross that abyss of young adulthood, and then the regressions and the mental health things, unfortunately, kick in more. So we really need to be more prepared for that, and be talking about it as early as we can, not to scare families, but if we're prepared, it's less likely to be such a big issue.
Dan, this one's for you. It's about the condition of intermittent explosive disorder. Maybe define it and talk about how is it a co-occurring condition with autism, and how do you manage it?
Well, intermittent explosive disorder really is, I think is a psychiatric term for just some behavior, which is explosive behavior that can be aggressive. It's a way of labeling something that we do see a fair amount in autism, right? We see kids who get frustrated and blow up and get aggressive. And I think we manage that by understanding in a multifactorial way what goes into those episodes, and helping them to do a kind of a collaborative problem solving approach to finding out what sets a child off, what their triggers are, and how to help them anticipate those and working on those sort of one at a time. And I think a lot of times it's not so much a disorder that needs treatment on its own, but more understanding the emotional and regulation underpinnings that go with that, in my perspective.
There's increased access and availability of marijuana, cannabis, and cannabis-derived products like cannabidiol. So let's talk about the impact of cannabis as a form of medicine for, the question is about adult autistic patients, but I think we can also talk about it for adolescent and young adults as well. And how do you think about now the presence of cannabidiol, medical marijuana now being available in the context of people with autism? I think I'll maybe Roma and Amy.
Well, I think one of the main points I want to emphasize is that there's no clear evidence for any indication for the use of marijuana or cannabidiol for individuals with autism, except for certain conditions associated with epilepsy. But otherwise, we have absolutely no clinical trials that they're going to be helpful for sleep, for anxiety, for depression. And we really don't know what the impact of these substances are on the developing brain. We also don't know what these substances are made of, right? You can purchase marijuana and cannabidiol from a certain vendor, but you can't be fully certain what ingredients are in the substance that you have purchased. So I just encourage, I don't recommend, and as a field, we aren't recommending cannabidiol or marijuana for any type of mental health indication. That being said, I know that sometimes adolescents are wanting to, are in peer groups, wanting to be accepted, are going to find the group that is going to easily take them in and can be misled to trying to use marijuana, and it really could result in harmful side effects. I think a lot of education and a lot of supervision is needed.
Amy, there's a question about how do you advise families of a child whose treatment approach has been largely deficit-based and has had adverse effects on their self-perception, sense of self-worth. How do you address that? And let's return to the topic of strength-based interventions as well.
Yeah, unfortunately, that's an all too common occurrence, I'm afraid. I think a lot of it comes from back to this workforce issue of not having enough providers also that are trained to really know how to work with autistic children and adults. I think it might start with parents acknowledging with their child that they recognize that maybe a previous provider wasn't a good fit. And potentially, seeing if the child will be amenable to meeting with and talking with other potential providers. I always encourage parents, although there are not a lot of providers to go around, that doesn't mean we should just take the first person that you connect with. It really is important that families find a therapist that is a good fit for them and for their child. And so, I always start my first therapy session saying, this is a time for you to kind of check me out and see if I'm a good fit, just like I'm finding out if I'm going to be a good fit to help you, and encouraging parents to take that perspective. And especially if there's a teen, encouraging them to be a part of that role as well. So they find someone that can really validate their strengths and take that positive perspective. I think also probably looking for someone who has experience working with autistic children is probably really important. As much as possible, so that they know the types of strengths and ways that they can validate the child.
A number of questions are about, we haven't really touched on diagnostic workup. So it's questions about brain imaging, about laboratory testing, genetic testing. Roma, perhaps you could comment on, we don't have a lot of time left, but maybe comment on a general approach to thinking about what a diagnostic evaluation for a child presenting for an autism workup what that looks like.
So the diagnostic evaluation of autism is a clinical evaluation, right? We determine if a child has autism based on a face-to-face interview with the family and with the child. And that could be observation of the child, talking with the child or adolescent, gathering a lot of history from parents, from the child or adolescent, and also maybe even getting collateral history from teachers, from daycare providers, from therapists, from pediatricians. We integrate all of that information to arrive at a diagnosis. Sometimes supplemental measures are needed. As Luke mentioned, there's a semi-structured assessment called the Autism Diagnostic Observation Schedule. That can give us some information about whether or not our child may have autism features. Sometimes parents fill out paper and pencil scales. We'll ask the child to fill out some scales. It's a very clinical diagnosis. In terms of any additional tests, there's no blood test to tell us if a child has autism. What blood work we need, what testing we need is genetic testing, because increasing evidence shows that there might be underlying genetic mutations that could be associated with autism. And knowing that could be very informative, because then we can learn more about, if we know a lot about what that genetic alteration is, and if it's associated with medical conditions or other outcomes, we can provide a more comprehensive treatment plan for the child. We obtain MRIs, EEGs, and any other tests indicated if we are seeing neurologic signs or symptoms, or any observational signs or symptoms that would suggest that there might be an underlying neurologic condition that's present and associated with autism.
I think that's all the time we have for questions. And we hope that you all have enjoyed this webinar and found the information to be useful. Please consider following Kennedy Krieger on our social media platforms to learn more about upcoming events or episodes of Exploring the Brain, news from Kennedy Krieger. And we'd love to know what other topics you'd like to learn about in future Exploring the Brain webinar episodes. The questions that came in, these wonderful questions, are already inspiring us to think about additional topics to cover down the road. And you'll be receiving an email from us in the next few days with a link to a recording of this episode to share with friends and family. So I want to thank our panelists, Dan, Amy, Luke, Roma. Thank you for sharing your expertise with us this evening, and for all of you for joining us for Exploring the Brain. And for more information about Kennedy Krieger Institute and how you can support us, if you'd like, please visit our website at kennedykrieger.org. So with that, wish you all a great night.